Imagine for a second that you're driving on a highway. It's a route you take every single day.
Okay.
You know every curve, every exit, you know where all the potholes are. But today, the stakes are completely different.
Mm-hmm.
Imagine that if you veer just a single millimeter out of your lane, you don't just, scratch your paint. Bop. You might lose your voice forever.
That is a terrifying thought.
And it gets worse. If you veer a millimeter the other way, you trigger this chemical cascade that causes your hands to lock up in these painful spasms.
Wow.
And if you stop too suddenly, you cut off your own air supply.
It sounds like a specialized nightmare scenario, doesn't it? But, I mean, for a surgeon operating on the neck, that is the daily reality.
Right.
It's a high-stakes environment where the margin for error isn't measured in inches, but in microns.
And that's exactly what we're unpacking today. We're looking at a procedure that is incredibly common, the thyroidectomy, so the surgical removal of the thyroid gland. But we aren't just reading a standard patient pamphlet here. We've got our hands on a clinical guide designed for advanced medical board exams. We're talking USMLE, NEAT PG level material.
The high-yield stuff.
Exactly. This is the stuff they use to train the people who actually hold the scalpel.
And what makes this source material so compelling to me is that it strips away all the comforting fluff. It focuses entirely on what we call the pearls. The critical facts that separate a routine recovery from a life-threatening emergency.
So we're effectively looking at a map of the hidden dangers inside the neck.
A map of the minefield, yeah.
The mission for this deep dive is to transform that clinical checklist into a story about human anatomy. We want to understand how a surgery in the neck can surprisingly affect your hands, your heart.
And even your ability to sing.
Even your ability to sing. It's just a fascinating web of connections, isn't it?
It really is. I mean, you've got nerves running through there that control your vocal cords. You have these tiny glands that regulate your entire blood chemistry.
And major blood vessels carrying oxygen to the brain.
All packed into this tiny space. So when you go in to remove the thyroid, you are, in fact, navigating a minefield.
So whether you're a medical student cramming for an exam, a patient who's prepping for surgery, or, just someone who wants to understand how fragile and resilient the body is, this is for you.
Mm-hmm.
We're going to break this down just like the clinical guide does, by time frame. So what happens early versus late, and by system nerves versus chemistry.
Shall we start with the most immediate danger, the thing that keeps surgeons awake at night?
Let's do it. The source material labels this the code red moment. We're talking immediate complications, and right at the top of the list in bold letters is postoperative hemorrhage.
Right. Bleeding. And to understand why this is so dangerous, you have to understand the geography of the neck. It's not like the abdomen.
Okay.
If you bleed in your belly, your stomach can distend. There's room for things to expand. The neck is different. It's packed with all these vital structures, the airway, the esophagus, major arteries.
But it's also wrapped in tight layers of fascia, right?
Exactly. Fascia, that dense connective tissue, like the white stuff you see on a raw steak.
Yeah.
In the neck, it's incredibly strong.
Yeah.
And it's non-stretchy. It creates a closed compartment.
Okay, so it's tight real estate. There's no wiggle room.
Zero wiggle room. So if bleeding occurs, that blood has nowhere to go. It just builds up pressure.
And that pressure doesn't just push outward, it pushes inward.
It pushes inward directly against the trachea, your windpipe.
So you're essentially being strangled from the inside.
Precisely. And the physics of it are unforgiving. The trachea is cartilage, so it's stiff, but with enough pressure from a hematoma, a collection of blood, it will collapse.
And the source material highlights that this usually happens within the first 6 to 24 hours after surgery. That's the danger zone.
That's the window, yeah.
Why that specific window, though? Why not, immediately in the operating room?
Well, in the operating room, the patient is under anesthesia. Their blood pressure is controlled. It's usually kept a bit lower to minimize bleeding. Everything looks dry and perfect when the surgeon closes up.
But then the patient wakes up.
And they wake up. The anesthesia wears off. They start to feel pain. Maybe they cough, or they strain to move over to the recovery bed.
Or they vomit.
All of those things spike the venous pressure in the neck.
And that spike tests the plumbing.
Perfectly put. It tests the plumbing. The mechanism is usually something called a slipped ligature.
Which is just the tie on the blood vessel.
Exactly. Ligature is the fancy word for the knot or tie used to close off a blood vessel. If that knot isn't perfectly secure, or maybe a metal clip isn't tight enough, that spike in pressure can just pop it right off.
And suddenly you've got bleeding filling up that tight space.
It could be arterial bleeding, which is high pressure and very fast, like a hose spraying. Or it could be venous bleeding. But in the neck, even a slow venous bleed is critical because of that limited space we talked about.
And the source gives us a very specific visual to look for. It's not just swelling. It describes a rapidly expanding neck swelling.
And a tight wound.
A tight wound. That's a visceral image, like the skin is drum tight.
Yes, shiny and hard. If you touch it, it doesn't feel soft like flesh. It feels like a rock. And clinically, the patient will start showing signs of respiratory distress. They might develop stridor.
Okay, break that down for us. What does stridor actually sound like?
Stridor is this high-pitched, noisy breathing sound. It happens when air is forcing its way through a narrowed passage. It sounds like a harsh squeak or a crowing sound on the inhale.
Oh, wow.
If you hear stridor after a thyroidectomy, you are in serious trouble. It means the airway is critically narrow.
Okay, so here's where the source material gets really intense. It outlines the management protocol. And it's not call for a scan or wait and see. It says, and I'm quoting, immediate wound opening at bedside.
This is one of the most dramatic actions in all of postoperative care. And the source emphasizes this heavily. You do not have time to wheel the patient back to the operating room.
No, Tom.
You don't have time to wait for the elevator. You certainly don't have time to wait for the anesthesia team to arrive.
Because every second counts.
Because the brain starts dying after just a few minutes without oxygen. If that patient cannot breathe because of a tense hematoma, you have to release the pressure right there, in the recovery room, on the ward.
That means cutting the stitches right there in the bed.
Yes. You put on gloves, you grab a scalpel or scissors, whatever's on the crash cart, and you cut the stitches. You open the wound completely. You might even stick your finger in to scoop out the clot.
That sounds incredibly invasive for a bedside procedure.
It is messy.
Yeah.
It's drastic.
Yeah.
And it is scary for everyone in the room. The nurses, the junior doctors, the family if they're there.
I can't even imagine.
But it is unequivocally life-saving. As soon as you open that wound and let the blood out, the pressure releases, the trachea springs back open, and the patient takes a massive gasp of air. You literally save their life in seconds.
It sounds almost medieval, but absolutely necessary.
It's just plumbing. If the pipe is crushed, you have to uncrush it. The pearl here, as the guide puts it, is that a tense neck swelling after this surgery is not just swelling, it's an immediate emergency.
That really drives home the airway first mentality. And the guide also mentions other things that can block the airway, doesn't it? Like laryngeal edema.
Yes, edema is just swelling of the tissues inside the throat, often from the breathing tube used during surgery or just the general trauma of the operation.
Right.
But the guide groups these together, hematoma, edema, and something called bilateral recurrent laryngeal nerve injury under one big banner, airway obstruction.
So the common denominator is just, can the patient get air in?
Exactly. The takeaway for you listening is simple. After neck surgery, the airway is king. Anything that threatens it takes priority over everything else. You can fix a scar later. You can fix a voice later.
So we can't fix dead.
You can't fix dead.
Speaking of fixing a voice, or breaking it, that brings us to our second segment, the voice. This is the stuff that might not kill you, but it can certainly change who you are. The source material spends a lot of time on nerve injuries.
It does, because the thyroid gland is basically draped right over the nerves that control your voice box. It's like the gland is a butterfly sitting on top of electrical wires. The most famous one is the recurrent laryngeal nerve, or RLN.
Why is it called recurrent? It sounds like it keeps coming back.
That's exactly what it does. It's an anatomical oddity. It comes down from the brain, goes all the way down into the chest, loops around the major arteries near the heart, the aorta on the left, subclavian on the right.
And then it travels back up?
It travels back up. It recurs into the neck to reach the larynx.
That seems like a massive detour.
It is. It's a total evolutionary quirk. But because it travels such a long, winding road through the chest and neck, it's incredibly vulnerable to injury in multiple places. And during a thyroidectomy, the surgeon is working right where that nerve re-enters the voice box.
And there are two of them, right? One on each side.
Correct. And the symptoms depend entirely on whether you damage one or both. The guide makes a very sharp distinction here. If you have a unilateral injury, so meaning just one side is damaged, what happens?
The guide says hoarseness, a weak voice.
Right. One vocal cord is paralyzed. It usually gets stuck in what we call a paramedian position, sort of halfway open, halfway closed. The other vocal cord works fine, but it can't quite meet the paralyzed one in the middle to vibrate properly. So you get that breathy, hoarse quality. It's a major quality of life issue. You can't shout. You can't be heard in a noisy room. But people can usually breathe okay.
Because one cord is still moving out of the way?
Exactly. But then there's the bilateral injury, both sides.
This is the nightmare scenario.
This is the nightmare scenario. If both nerves are damaged, both vocal cords can become paralyzed. And if they both paralyze in that halfway position, the opening for air becomes extremely narrow. It's like trying to breathe through a coffee stirrer.
So instead of just a bad voice, you get stridor and respiratory distress.
Exactly. So bilateral RLN injury isn't just a voice problem, it's a breathing problem. That's why the source labels it a surgical emergency. You might need a tracheostomy, a hole in the neck, just to breathe, because the natural door is jammed shut.
That is terrifying. But there's another nerve the guide mentions, one that I think is even more fascinating because it's so subtle. The singer's nerve?
Yes, the external branch of the superior laryngeal nerve. It's a mouthful, so we usually just call it the external laryngeal nerve.
Right.
But the guide is very specific about what happens if you nick this one. It says it does not cause hoarseness.
Wait, so if the nerve is cut, you don't sound hoarse. That seems completely counterintuitive.
Right.
If I cut a nerve to my voice box, I expect my voice to sound broken.
It does sound counterintuitive, and that's where a lot of non-specialists get confused. This nerve doesn't control the main muscles that open and close the cords. It controls one specific muscle called the cricothyroid.
The cricothyroid, what does that do?
Its only job is to stretch and tense the vocal cords.
Like tightening the string on a guitar.
That is the perfect analogy. Think about a guitar. When you want to play a high note, you tighten the string. When you want a low note, you loosen it. The cricothyroid muscle is your tuner. If you paralyze that muscle, you can't tighten the cord. You can speak in a normal tone, you can drone on in a monotone just fine. But you cannot hit high notes. You lose your entire upper register.
The guide lists the symptoms as inability to raise pitch and voice fatigue. It calls it the loss of singing voice.
Right. I mean, imagine being a professional opera singer. Your career depends on that high C.
Or even a teacher.
Or a teacher who needs to project their voice across a noisy playground. That projection requires pitch modulation. You wake up from surgery, you say hello, and you sound fine. The surgeon says, great job, everything is normal.
But then you try to shout.
You try to shout or try to sing a high note, and the voice just breaks or disappears. It is devastating for careers.
It's an invisible disability until you try to use that one specific function. So the pearl here is distinguishing that cricothyroid paralysis affects pitch, whereas RLN injury affects the quality of the voice itself.
That's the key distinction.
So how do surgeons prevent this? Is it just luck?
No, it's anatomy and technique. The guide says the golden rule is visual identification. You have to see the nerve. You can't just assume you know where it is based on a textbook because everyone's anatomy is slightly different.
So you have to physically dig for it.
Gently, yes. You have to find it, look at it, and then carefully tie off the blood vessels, specifically the superior thyroid vessels, very, very close to the gland.
Why so close?
Because the nerve runs right alongside those vessels. If you tie the knot too far away from the gland, you might catch the nerve in the ligature.
It really is a game of millimeters. You tie the knot 2 millimeters to the left, and the patient never sings again.
It really is. That's why head and neck surgery is considered one of the most delicate specialties. But let's shift gears. We've talked about blood, the plumbing, we've talked about nerves, the wiring. Now we need to talk about chemistry. Because the thyroid doesn't live alone in the neck. It has neighbors.
The parathyroid glands. This brings us to segment 3, the chemistry crisis. The source identifies hypocalcemia, low calcium, as the single most common complication after a total thyroidectomy.
Yes. And this is a huge point of confusion for patients. They hear thyroid surgery, and they assume any hormonal problems will be about thyroid hormones, metabolism, weight gain, that sort of thing.
Right, that makes sense.
But the immediate chemical crisis is actually about the parathyroid hormones.
So what exactly happens? Do they accidentally remove these glands?
Sometimes. Sometimes they're accidentally removed because they're tiny, about the size of a grain of rice or a lentil.
Wow.
And they're often embedded right into the surface of the thyroid tissue. They're camouflaged. You can look right at them and think they're just a little bit of fat or thyroid tissue.
But the guide says it's not always removal. It mentions devascularization.
Right. This is actually more common. Devascularization just means cutting off the blood supply. So the surgeon preserves the gland. They leave it physically there in the neck. But in the process of tying off the blood vessels to remove the thyroid, they inadvertently choke off the tiny capillaries feeding the parathyroids.
So the gland is there, but it's starving.
Exactly. And these glands are very, very sensitive. They go into shock. They just stop producing PTH, parathyroid hormone.
And PTH is what keeps our calcium levels up.
Correct. PTH is the thermostat for calcium. It tells your bones to release calcium into the blood, and it tells your kidneys to hold on to calcium. Without PTH, your kidneys flush calcium out, and your bones stop releasing it. Your blood calcium drops like a stone.
And the guide says this typically happens within 24 to 72 hours.
That timing is key. It's
Yeah.
rarely immediate. The body has a little reserve, so the patient might be feeling okay immediately after surgery in the recovery room. They might even go home the next day feeling fine, but then 2 days later, things start getting weird.
And weird is the right word. We tend to think of calcium as just bone stuff, drink milk for strong bones. But calcium is actually the electrolyte that stabilizes your nerve endings.
This is the crucial concept. Calcium keeps the electrical gates on your nerves closed. When calcium is low, the threshold for firing drops. The gates fly open way too easily, your nerves become hyper-excitable, they start firing on their own without the brain telling them to.
The guide lists the early signs. Perioral tingling, so tingling around the mouth, numbness of the fingers, and muscle cramps.
That tingling around the mouth is usually the first warning shot. It's very specific. If a post-op patient says, "My lips feel fizzy," or "My face feels like it's asleep," or "I feel like I have ants crawling on my lips," you check their calcium immediately. That's the nerves in the face starting to misfire.
But if you miss that, it progresses. And this connects to segment 4, which I found really surprising. The guide talks about musculoskeletal manifestations. When I think of neck surgery, I don't think of pain in my wrists or my ankles.
This is a fascinating mimic. Severe hypocalcemia causes the muscles to contract uncontrollably. But because of the way the muscles pull, it can look and feel like a joint problem.
The source mentions painful muscle spasms and stiffness around the wrists, ankles, and knees. It even says it can mimic arthritis or joint locking.
Right. Imagine your hand cramping up so hard it feels like the wrist is locked solid. A patient might say, "Oh, my arthritis is flaring up because of the uncomfortable hospital bed." They might ignore it or ask for a painkiller.
But it's not arthritis.
It's not arthritis, it's the chemistry. The muscles are contracting so hard they are freezing the joint.
And there's a hallmark sign for this, isn't there? Carpopedal spasm?
Yes. Carpo refers to the hand and wrist. Pedal refers to the foot. It's a very distinctive spasm. In the hand, the fingers extend straight out, but the knuckles flex at a 90-degree angle and the thumb tucks in across the palm.
That is a very specific shape.
It is. It looks almost like the hand is making a puppet shape. It's sometimes called the obstetrician's hand.
Obstetrician's hand? Why on earth is it called that?
It's an old term referring to the hand position used during certain manual deliveries back in the 19th century. The hand is cupped and narrow. But if you see a patient with their hand locked in that position today, usually they're terrified and in pain, and it's almost certainly low calcium.
And the guide mentions 2 classical clinical tests, names that strike fear into the hearts of medical students everywhere because they always come up on exams.
Oh, yes.
Trousseau's sign and Chvostek's sign. Let's break those down.
Sure. These are bedside tests to see if the nerves are irritable. They're basically ways to provoke the nerves. Chvostek's sign is the face test. You tap the patient's cheek right over the facial nerve, just in front of the ear.
Just a little tap?
Just a light tap with your finger. If their calcium is normal, nothing happens. But if their calcium is low, that light tap is enough to trigger the nerve. The facial muscles will twitch or spasm on that side, the lip will jump, the nose might twitch. It's a clear sign of hyperexcitability.
And Trousseau's?
Trousseau's is more specific and arguably more useful. You put a blood pressure cuff on the patient's arm, and you inflate it above their systolic pressure. So you cut off the blood flow completely.
That sounds pretty uncomfortable.
It is a bit. You leave it there for about 3 minutes. And that causes a little bit of ischemia, lack of oxygen in the arm nerves. In a normal person, their arm just goes to sleep.
But in a hypocalcemic patient?
In a hypocalcemic patient, that little bit of stress is enough to irritate the already angry nerves. Their hand will involuntarily cramp up into that carpal spasm we just talked about, the obstetrician's hand.
It's incredible that you can diagnose a chemical imbalance just by squeezing someone's arm with a cuff.
It really is. It shows how interconnected the systems are. You're using a mechanical test to find a chemical problem, but we have to respect it, because if you ignore these cramps, it doesn't just stop at the hands. The guide warns about severe manifestations.
Laryngospasm.
Yes, the muscles of the throat can spasm just like the muscles of the hand. And if the throat spasms, the airway closes.
So we're back to the airway again?
And we always circle back to the airway. If the vocal cords spasm shut, you can't breathe. The guide also mentions seizures and cardiac arrhythmias. Calcium is essential for the heart to beat properly. So low calcium isn't just uncomfortable, it is potentially fatal.
And the pearl here is, if a patient has laryngospasm after thyroidectomy, your immediate thought shouldn't just be swelling.
It should be low calcium, exactly. Treat the chemistry and you relax the muscle.
So let's talk about treating it. Segment 5 covers management. If someone's lips are tingling, what do we do?
If it's mild, just some tingling, maybe mild cramping, and they can still swallow, we give oral calcium and vitamin D.
Okay, why vitamin D? Is the calcium not enough on its own?
Vitamin D is crucial because it acts like a key to unlock the gut so it can absorb the calcium. Without vitamin D, you can take all the calcium pills you want and they'll just pass right through you. You need the key to open the door.
I see. But if they're having seizures or heart issues or severe spasms where they can't swallow?
Then you need the heavy artillery, 5-E calcium gluconate.
Hmm.
You bypass the gut and put it straight into the blood. But the guide has a very specific safety note here that I want to highlight because this is a classic medical error.
Okay.
It says, it must be given slowly and with cardiac monitoring.
Why slowly? I would think if they're seizing or their throat is closing, you want to push it as fast as possible.
That intuition is so dangerous here. If you push calcium into the veins too fast, you flood the heart muscle. The heart muscle uses calcium to contract. If you give it a massive bolus of calcium all at once, you can actually cause the heart to seize up in a contracted state.
It stops the heart.
Yes. It can cause a cardiac arrest in systole, the contracted phase. It's sometimes called stone heart. The heart just clamps down and won't let go to fill up with blood again.
Wow.
So you're trying to save them from an arrhythmia, but if you rush, you cause a different fatal one.
It really is a balance. Too little is bad, but too fast is fatal.
Medicine is always about balance. It's not just about the right drug, it's about the right speed. You have to push it over 10 to 20 minutes, watching the ECG monitor the entire time.
Now, what about the long term? The guide mentions late complications.
Well, the most obvious one is hypothyroidism. If you remove the whole thyroid because of cancer or a large goiter, you have no source of thyroid hormone. That is 100% expected.
Right.
The patient will need to take a pill thyroxine every day for the rest of their life.
That's the trade-off. You lose the organ, you take the pill.
It is. Then there's permanent hypoparathyroidism. That's defined as low calcium lasting more than 6 months.
The guide says this is rare if the technique is proper.
Rare with proper technique. That's the surgeon's burden. If you're careful, the parathyroids usually wake up, they recover from the shock of surgery, they revascularize, and start working again.
But if not,
But if you were too aggressive, or the anatomy was messy and you remove them all, they might be gone forever. And that means lifelong calcium supplements, which is a difficult regimen to manage because calcium pills are large, they're chalky, and can cause a lot of stomach issues.
and then, of course, scarring. Keloids or hypertrophic scars on the neck.
Which, for many patients, is a significant concern. It's a visible reminder right on the neck, a very exposed part of the body. It affects how people dress, how they see themselves in the mirror.
The guide sums up prevention with a simple but powerful phrase. Good surgery is the best prevention.
It sounds obvious, right? It's like saying drive carefully. But in this context, it means meticulous hemostasis, stopping every little bleeder so you don't get that hematoma and identifying and preserving those parathyroids. You can't fix what you don't see.
This brings us to the final segment of the source material, the exam mindset. This is where we learn to think like a clinician. The guide emphasizes symptom-cause correlation. It basically wants you to be a detective.
Right. In an exam and in real life, the patient doesn't walk in with a label on their forehead saying, I have a slipped ligature. They walk in with a symptom.
Yeah.
You have to work backwards from the complaint to the anatomy.
Okay, so let's run through the rapid associations, the source lists. I'll play the exam proctor, you play the student. I'll say the symptom, you tell me the cause.
Go for it. I'm ready.
Symptom, hoarseness immediately after surgery.
Cause, unilateral recurrent laryngeal nerve injury. One cord is down.
SIMIP, loss of pitch, can't hit the high notes, but the speaking voice is normal.
Cause, external branch of the superior laryngeal nerve, the singer's nerve.
Symptom, stridor, that noisy high-pitched breathing.
Okay, that's the danger zone. Could be bilateral RLN injury, or it could be a hematoma compressing the airway. You have to check the wound immediately.
Symptom, joint stiffness and hand spasms.
Hypocalcemia, low calcium. Look for the obstetrician's hand.
You passed. Phew. Thank you. So the guide also warns about Traps, mistakes that even smart people make. And one of them is confusing hypocalcemia with hypothyroidism.
This is a huge trap because they sound so similar. Hypothyroid versus hypocalthyroidism.
Hmm.
But you have to look at the symptoms. Hypothyroidism, lack of thyroid hormone, makes you tired, gain weight, feel cold. It's a slow, sluggish metabolism.
It takes weeks to develop.
Weeks. And hypocalcemia, lack of parathyroid hormone. It makes you twitchy, crampy, and irritable. One is slow and cold, the other is fast and electrical. They are total opposites physiologically.
Another trap. Assuming hoarseness is always a nerve injury.
Right. I mean, if you stick a breathing tube down someone's throat for surgery intubation, their throat is going to be sore and swollen. They might be hoarse just from the plastic tube irritating the cords.
So you don't panic right away?
You don't panic,
Yeah.
but you do have to rule it out. Often, we'll use a tiny camera to look at the cords to see if they're moving. If they're moving but swollen, it's the tube. If one isn't moving, then you know it's the nerve.
And the biggest trap of all, according to the source, forgetting what kills fastest.
Yes. Students often obsess over the nerve injuries because the anatomy is complex and it's interesting, it's intellectual.
Sure.
But a hematoma bleeding kills faster than a nerve injury. A nerve injury might ruin your voice. A hematoma ruins your ability to breathe now.
The key takeaway quote here is just fantastic. Symptoms guide diagnosis more than labs.
That's the art of medicine, right
Yeah.
there. You look at the patient, not just the spreadsheet. If the patient is gasping for air, I don't care what the blood work says yet. I don't care if the calcium result is pending in the computer system.
Right.
I need to secure the airway or open the neck. You treat the human in front of you.
So let's wrap this up. We've covered a lot of ground today. If we had to distill this entire deep dive into a rapid summary, what are the headlines?
Okay. Number 1, hemorrhage is the most dangerous complication. It requires immediate bedside action. Cut the stitches. Don't wait.
Got it.
Number 2, airway is priority.
Hmm.
Always. Whether it's blood, swelling, or bilateral nerve paralysis, if air isn't moving, nothing else matters.
Mm-hmm.
Number 3, hypocalcemia is the most common complication. Watch for the tingling lips and the cramping hands. And remember, it mimics joint issues, but it's chemistry.
And the last one.
And finally, know your nerves. One affects the tone, the other affects the pitch.
It's amazing when you think about it. We started talking about a standard surgery, and we ended up discussing acoustics, electricity, fluid dynamics, and emergency plumbing.
That's the beauty of the human body, and is the burden of the surgeon. A millimeter difference in technique determines if a patient can sing a lullaby, if they can breathe freely, or if their body chemistry stays in balance.
It really highlights the concept of transience versus permanence. A drop in calcium is a transient chemical state, but it can mimic a permanent joint disease. A temporary swelling can look like a permanent nerve injury.
And identifying the difference, knowing when to wait and when to cut, that's what clinical medicine is all about. It's about recognizing the pattern before it becomes a disaster.
And for you listening, the next time you hear someone mention thyroid surgery, or if you just look in the mirror and see that little area in your neck, you'll know it's not just a quiet bystander. It is sitting at the most crowded, high-stakes intersection in the human anatomy.
Always ask why when you see a symptom. Is it the nerve? Is it the blood? Is it the chemistry?
Thanks for diving in with us. We'll see you on the next one.
Shake here.